A woman, Miss B, injured her right wrist and was referred to an orthopaedic surgeon. During the consultation, a trainee doctor was also present. The recommendation from Dr. A was to work with a hand therapist and reconvene to review in 2 months' time. During the second consultation, the woman first saw the trainee, Dr. D, where they discussed, according to the trainee, the full extent of the surgery, including the placement of a plate and screws to fix her ulnar bone. However, this conversation was not documented. Contradictory to Dr. D, the woman says that she was never informed about the placement/use of a plate and screws. She then saw the orthopedic surgeon, Dr. A, where he got her to sign the consent form and did not explain any parts of the surgery, as he was under the assumption that she had already been informed by Dr. D. Following the surgery, Ms. B suffered other complications and saw a different orthopedic surgeon.
There are 4 main ethical concerns relating to this case. Firstly, there is the issue of valid consent because Dr. A did not provide Mrs. B with all the information relating to her surgery, specifically regarding the cutting of the ulnar and insertion of the plates and screws. Ms. B could not be expected to give valid consent to the surgery. This leads us to the issue of Mrs. B's autonomy, which was undermined by Dr. A when he failed to provide her with all the information relating to her proposed surgery. Dr. A acted paternalistically in assuming he knew what was best for Mrs. B and withholding pertinent information. Finally, there is the issue of justice. Because Dr. A and the other health practitioners did not keep comprehensive notes, this could impact Mrs. B's future care under other physicians and could lead to inequality between her and other patients.
So in terms of Dr. A justifying his actions, both Dr. A and Dr. D were acting in Miss B's best interest in her having the surgery. Regardless of how informed or not Miss B was, this was the best course of action for her. She'd already been through hand therapy and this did not work. And this was the next appropriate step for her from a beneficent perspective, and it appeared to be the greatest imperative of doing right. From a consequentialist approach, Dr. D did not do anything ethically wrong. Dr. A had confidence in the ability of his colleagues, Dr. D and the nurses to communicate information to Miss B. There were several instances of this, from Dr. D first discussing treatment options with Miss B, to the nurses talking to Miss B on the phone before her operation and on the day of the operation itself. It does not seem to have been his intention to have neglected providing Miss B with all the information for obtaining valid consent.
Dr. A appears to be acting with Miss B's best interest in mind. However, he acts in a paternalistic way. He neglected Ms. B's right to autonomy and her right to make informed consent when he did not present to her all the information about the surgery, which is required before she can give informed consent. Although he believes the surgery is the best option for Ms. B, the importance of providing her with all the information so she can decide what is best for herself overrides the principle of beneficence. Ms. B may still have decided to go ahead with the surgery had she been given all the information, but this would have been her decision. He also failed to check and keep adequate records of all the conversations had with Ms. B, and never made the effort to see the documentation outlining what information Ms. B had been told about the surgery by Dr. D, impairing appropriate communication of information.
Okay, so some of the strategies that we identified to reduce ethical risk were Dr. A and his practice could employ a number of techniques for reducing ethical risk. They could provide printouts with diagrams and explanations of procedures and talk through these with patients and then send them home with a copy, for example, to read over before signing the consent form. To protect Dr. A from future ethical risk, better record-taking practices would have been required. This might have meant allocating more time to writing comprehensive notes or like a note-taking template. In this case, there was not a clear documented conversation between Dr. A and Dr. D about what specifically was explained to Mrs. B in Dr. D's consultation. However, as Dr. A is ultimately responsible for ensuring Mrs. B's full knowledge of the procedures, it's essential that he comprehensively explains that procedure to her, and Dr. D's input is simply additional.